Thank you for joining Women Heart, the National Coalition for Women with Heart Disease, for our webinar, Women, Sleep Apnea, and Heart Disease, What Women Need to Know. Special thanks to our webinar sponsor this evening, the RedMeds Foundation. I'm Emily Swartz, Senior Associate of Public and Patient Programs for Women Heart, and next to me is Eva Maszewski, Manager of Communications and Marketing. Today you will hear from Dr. Phyllis C., Benjamin and Virginia T. Boshes Professor in Neurology at Northwestern University, also Director of the Northwestern University Center of Medicine and Sleep Disorders, and Director of the Center for Circadian and Sleep Medicine at Northwestern University Feinberg School of Medicine. Her presentation will be followed by a Q&A session where you will have the opportunity to ask Dr. Z all the questions you have about sleep apnea in women. I will go ahead and provide those instructions later when we come to that and how to submit your questions for the Q&A. So without further ado, I'm going to turn it over to Dr. Z.
Emily, thank you very much for that introduction. And I'd like to welcome our participants. Good afternoon and good evening to some of you in joining me for this webinar. I want to also disclose that I am on the board, a scientific advisory board for Merck and Phyllis, and my husband owns stock ownership in Teva and Express Scripts. I do not think that any of these relationships will impact directly on this presentation. Next slide, please. So why is sleep important? I think all of you on this call know that it must be important because you spend about at least a third of your day, if you're lucky, sleeping. But yet, despite this kind of really that sleep is imperative for health, about 50 to 70 million Americans are affected by chronic sleep disorders or insufficient sleep. Nearly 1 in 3 adults report frequent insufficient sleep, and I think what really puts us also at risk is that nearly 5% of drivers actually admitting to falling asleep in the past 30 days while driving. Untreated sleep disorders have been linked more recently not only to performance issues, sleepiness and tiredness, but also to very important health problems, and specifically for this group with heart disease, including hypertension, stroke, mood disorders like depression, diabetes, and other kind of health issues, including disorders of the immune system. Next slide, please. In addition to this relationship with kind of disease and risk for cardiovascular disease, there's really kind of important new findings in the area of sleep research. We now know that in just normal, usual people, including children and young adults, as well as older adults, that sleep is critical for cognition and learning. And if you learn something and then you're allowed to sleep after that, you're able to consolidate that memory better. It's important for physical performance, for mental health. Lack of sleep, and especially chronic insomnia, has been associated with, for example, with depression. And as I said earlier, physical health being very important. We know that lack of sleep and short sleep duration is associated with, for example, increased risk for diabetes, gastrointestinal problems, immunological problems, and of course cardiovascular disease risk. Safety is a major issue. There's this group called Moms Against Drowsy Driving, not just drunk driving, because of the potential for car accidents and other types of accidents, especially in some of our younger adults and adolescents. Next slide. Well, all Americans are at risk for insufficient sleep and sleep disorders, but women really are a population of particular risk. This slide shows some data from the National Sleep Foundation poll that was done in 2007 of Americans. And what it really shows is that almost about 60%, 2/3 of women report only getting a good night's sleep infrequently. So most women are not getting sufficient or adequate amount of sleep. There are many causes for this, of course. One are lifestyle changes. There could be, just prioritizing sleep because women, have to take care of the family, children, and across the lifespan, menopause or perimenopausal time can certainly also be associated with changes in the biology, pregnancy. These changes in hormones and biology can also adversely affect sleep. But then there's also sleep disorders such as restless legs, and as well as what we're going to be talking about, that of sleep apnea. Next slide.
Okay, so we have actually reached our first poll question. I'm going to read the question to you, and then I will ask you to answer it. So our first poll question is, have you heard of or have you been diagnosed with sleep apnea? Okay, thank you for your responses. And Dr. Z, back to you.
Thank you, Emily. So what is obstructive sleep apnea? It's very common, and it is a serious sleep disorder. It isn't just about snoring. It's a condition where a person's breathing is either restricted or actually there's a complete cessation of breathing for periods of 10 seconds or longer. The upper airway is either partially obstructed or completely blocked, usually by the soft tissue, and that includes the tongue. It could be also what we call that little tongue that sits in the back of the throat called a uvula that can also block this area. And by increasing that pressure, the upper airway can collapse intermittently during sleep, particularly when somebody's sleeping on their back. It's oftentimes associated with snoring, and the slop breathing episodes and the snorting, sometimes the gasping for air, is oftentimes noticed first by the sleep partner. There are two major types of respiratory events that occur that we call sleep apnea. We kind of lump them together. One is a hypopnea, and that merely means that it's not a complete stop breathing episode, but rather a shallow or slow breathing, but it is still associated with oxygen desaturation. So not breathing decreases that oxygenation. Apnea refers to when you actually have a pause in breathing for 10 seconds or more, and also that results in a low oxygen saturation that can occur intermittently, and in some individuals can occur up to a few hundred times per night. Next slide. The severity of sleep apnea can be defined by how many of these stop breathing or shallow breathing episodes you have per hour of sleep. So if you have 5 to 10 of those, that's considered to be pretty mild. If you have 15 to 30 per hour, that would be moderate. And severe would be more than 30 or more per hour. So that would mean that almost every minute or every other minute you're having a stop breathing episode. In addition to causing your oxygen to go down intermittently, it also keeps you, the only way to stop this stop breathing episode is actually your brain to wake up intermittently, and then that will start the breathing again. So individuals with sleep apnea are also more prone to accidents because they're not getting sufficient sleep. The immune system is also altered, and as we said earlier, how sleep is important for memory consolidation as well as for mood regulation. The recent evidence points very strongly also that individuals with sleep apnea, especially more moderate to severe sleep apnea, are also increased risk for cardiovascular problems, including it's a risk factor for stroke, hypertension, and even cardiac death. Next slide. I think we mentioned earlier that sleep apnea is common. It affects about 18 million Americans. It is twice as common in men than in women across the lifespan. And this is particularly true in a younger and middle-aged group. But as women grow older, and especially around the time of menopause, the sleep apnea can become more prevalent. And in fact, women's prevalence catches up with that of men around the time of menopause. Pregnancy is another period where women are maybe at increased risk for obstructive sleep apnea. In fact, we have a study ongoing right now, which is a very interesting study to look at, does having sleep apnea in pregnancy increase the risk for future cardiovascular disease, and not just during pregnancy, but post, during, in the future? Is that somehow a setup for that? It is clearly more common in women and men who are overweight or obese, and also as one gets older. Therefore, the epidemic of obesity has actually also increased the overall prevalence of obstructive sleep apnea. So the range could be anywhere from 4% in the general population to even as high as maybe 20 to 30% in older people. Next slide. The evidence that is very strong, and I think that's really gained a lot of attention more recently, is the relationship between sleep apnea and the heart and the cardiovascular system. Untreated sleep apnea, especially in the moderate to severe range, has been shown to be associated with high blood pressure. In fact, it's a risk factor for high blood pressure, and should be considered in anyone who has poorly controlled hypertension. It is a risk factor for heart attacks or MIs, and also because of the low oxygen saturations that can occur intermittently, and also these awakenings and arousals, it can also be a risk for some of the cardiac arrhythmias. Atrial fibrillation is one of those that can be associated with sleep apnea, especially obstructive sleep apnea. Stroke, sleep apnea is also a risk factor for stroke. The link is strong in women as it is in men, and actually may even be stronger in women. For example, young women who may have had a stroke, clearly we should be thinking also of the possibility of obstructive sleep apnea. The most likely changes may be due to, when you have the apneic event, your heart rate changes, your blood pressure, instead of going down during sleep, which is what occurs naturally, is spiking throughout the entire night. And also these changes in low oxygenation intermittently during the night can be risk factors for the development, or mechanisms for the development of cardiovascular disease. Next slide. As we said earlier, it is a risk factor, and not only for stroke and heart disease and also heart failure, but if you already have existing heart disease or have had a stroke or some type of cardiovascular disease, whether it includes such as even hypertension, it can actually, untreated sleep apnea can worsen those conditions. Not only is it a risk factor, but it can also worsen those conditions. It is thought to play because it's thought to play a role in what we call sympathetic activation. By waking up continuously, intermittently throughout the night, having these arousals, can increase your sympathetic surges, which can increase your heart rate intermittently. It also can change the function of that inner lining of the arteries, which actually is very, very important for contractility of the vessel. Because of the increased workload on the heart with sleep apnea, it also can be associated with left atrial enlargement, and thus is a risk factor in some individuals for heart failure. We talked about inflammation as well, because the lack of oxygenation intermittently and all these awakenings and arousals can affect the immune system. There's very strong evidence also for association between sleep apnea and metabolism, and particularly that with diabetes. It's been shown to be a risk factor for diabetes. And in both situations for hypertension and diabetes, treating the sleep apnea with certain treatments, which we'll talk about in a little bit, can help ameliorate or reverse some of these effects. Next slide. So getting to the mechanisms, how do these sleep apneic episodes or these pauses in breathing or shallow breathing affect this outcome of cardiovascular disease? One, we talked about oxygen levels going down, then the body alerts the brain to tell the blood vessels to constrict the blood flow so they can get more to the heart and to the brain. And this can happen repetitively across the night, tens of times or hundreds of times, which can lead to arousal, this decreased oxygenation, altering the physiology of your blood vessels, which then can lead to hypertension and heart disease. Next slide. The risk factors for sleep apnea are similar in both men and women, but particularly women, both overweight and being obese is a risk factor. Structural issues, I think, is oftentimes overlooked. You can actually be thin and have a very small jaw, for example, or a very flat face, or a very thick neck. Those can, in themselves, these maxillofacial structure changes can also be a risk factor. So you don't always have to be overweight or obese to have sleep apnea. Older age, as we mentioned earlier, especially women during the perimenopausal years or postmenopausal. Smoking increases the risk for sleep apnea. Alcohol is definitely especially in people with sleep apnea, can worsen the sleep apnea. There's a family history of predisposition for sleep apnea, and having high blood pressure or diabetes is associated with sleep apnea. So if I have a patient who snores and has high blood pressure or diabetes, I actually would have a higher index of suspicion they may also have sleep apnea. Some other breathing problems like asthma or COPD can also increase the risk for sleep apnea. Next slide. So one of the things that's gained, we tend to think about people with sleep apnea as being, obese and weight gain. How does that relate to each other? Well, obesity, as many of you already know, is a risk factor for heart disease, stroke, and diabetes. But it's also a risk factor for sleep apnea. Sleep apnea then, in turn, itself can increase the risk for heart disease, stroke, and diabetes. And having heart disease can also, in a bidirectional relationship, affect the risk for sleep apnea. So it's really kind of a circular thing. And thus, it's really important to identify sleep apnea and treat the sleep apnea because because it is this bidirectional relationship. Treating the sleep apnea can actually potentially avert or ameliorate the cardiovascular disease risk. Next slide. Here are some of the signs and symptoms of sleep apnea. How do you know? Well, we said loud snoring. Individuals may experience in the middle of the night that they're choking, gasping sounds during sleep, or gasping, choking sounds. They may wake themselves up from gasping, arousals. The sleep tends to be restless because they're moving around. There may be frequent arousals and awakenings that the individual may or may not be aware of, but the partner may be bothered by some of these movements. Being tired and sleepy during the day. So if you snore and you're sleepy, excessively sleepy during the day, and have trouble concentrating or falling asleep at work, that combination is a very strong indication that one should at least be screening that person or that patient for sleep apnea. Morning headaches because of the low oxygen saturation during the night. Because many people with sleep apnea are breathing through their mouth tends to be dry. They have dry, chapped lips. Moodiness, irritability, and depression are also kind of comorbid or conditions are associated with sleep apnea. They're not very specific, but you may see this in increased frequency in patients with sleep apnea. Next slide. What's I think also very important is that women with sleep apnea may not present the same way that we classically think about men with sleep apnea, which is like they snore, they're excessive sleepy. Women have additional factors. They may present with, I'm not sleeping well, with depression, anxiety, hypothyroidism, and rather than just saying I'm really, really sleepy, during the day, they may actually present with insomnia symptoms, more common in women than in men. And so, especially perimenopausal, postmenopausal women says, I'm having trouble sleeping or staying asleep. We shouldn't just toss it up to insomnia, but actually think also about the potential for sleep apnea. Diabetes is a risk factor, as we said earlier, asthma, and also kind of having nasal allergies or nasal congestion. And women with sleep apnea may actually also present with like heart palpitations and swelling in their ankles. This may be true for men too, but these are signs that we don't typically think about being associated with sleep apnea. So women with sleep apnea may have slightly different presentation, and so we should be aware of that. Next slide. There are other gender differences, I think, that are notable. Women tend to have lower this apnea-hypopnea index, so they tend to have what we would call more mild, moderate sleep apnea. But yet, they will have a lot more of these partial obstructions. They may have more arousals. They also can score, when we look at these screening questionnaires for sleep apnea, they may score a little lower. And some of these questionnaires are basically developed and I would say validated initially in men and may not be as sensitive for women. And there's some recent studies that there may be more central nervous system or brain damage, especially in the areas of the brain that are involved in decision making and mood regulation, that may show some gender differences. Next slide. How do we then diagnose sleep apnea? One of the important things, I think the first thing, is to be aware of some of the symptoms of sleep apnea. It is indeed best detected and treated by a sleep medicine specialist, but it can be treated and identified by any primary care doctor or practitioner, nurses, PAs, and also your obstetrician and gynecologist. It is typically based on the physical exam, looking at the upper airway, the neck size. But most importantly, I think, is to be able to do some screening questions. Do you snore? Are you excessively sleepy during the day? Is your sleep disrupted? Do you gasp for air? Are there any witness apneas? I think those are just simple questions to ask yourself, but also, of course, your physician to be asking. It is diagnosed if you have a high index of suspicion, then it actually requires a sleep study and some other types of particular sleep study, which can be done in the laboratory or at home. Next slide. We went through this a little bit, but these are some of the questions that you may ask yourself. Do you have headaches, especially in the morning, and then they go away? Do you snore loudly? Has your partner or roommate noticed that you snore or stop breathing for a period when you sleep intermittently? Do you feel tired, fatigued, and sleepy during the day? And very importantly, how sleepy are you? Have you fallen asleep at work while talking to someone? Well, that's pretty sleepy. But usually, just do you feel that you're sleepier than usual? Next slide. The sleep studies, it's also called polysomnography. That means that that we're measuring here not just your breathing, but we're measuring your heart rate, your brain waves as well, to be able to kind of look at the entire picture of your sleep. It usually is done in a laboratory. It does not have to be a hospital. It could be a clinic, for example, or as I said earlier, it can be done also at home. The most important part of the sleep study is that it measures your blood oxygen levels through this little what we call pulse oximetry, measures your heart rate. So there's a one lead EKG, measures your breathing, both your ability to breathe, the timing of your breathing, but also the effort. So there's these two belts that are put on your chest and your abdomen to actually tell us whether you're making any effort to breathe during these stop breathing episodes. It can also help diagnose some patients with restless legs, for example, by doing this muscle bot, because there's also on your arm and legs, there's a couple electrodes put on to look for leg movements. Next slide. There is another option, which you can see in this picture here. It looks very nice. It's a portable device. This is a device that can be used at home. Typically, you would come to a sleep center, and a technician will show you how to connect this machine. The only thing it has is, as you can see from that picture, a little cannula that's placed over your nose and a little bit underneath your mouth here. And what it does is that it picks up your breathing movements. And then there's a belt that's worn, and that belt will also pick up and see whether you're making any movements to actually breathe, so it's expansion and contraction of your chest and abdomen. It is a much easier option than coming into a sleep center, but what it doesn't do is does not record your brain waves, so we don't really know whether the individual is actually sleeping or not, and in some cases it is important to know that, and it tends to then, in general, underestimate the amount of sleep apnea compared to the severity that may be actually seen in the sleep center. But it is a very, very useful method, and it's becoming first line for many individuals, especially for patients who are generally in pretty good health. If you really need more, if you have heart failure or you have heart disease and breathing disorders, then we oftentimes elect to do the sleep study in the hospital or in a lab in a clinic. Next slide. How do we go about treating sleep apnea? I think this is why it's so important to recognize it, because you can treat it. It's a treatable condition. The overall approach is to keep that airway open, because it is collapsing during sleep. By doing that, we can relieve some of the symptoms, especially promoting better sleep quality, improving cardiovascular function, and metabolic function, and overall improving the quality of life of individuals. Those are the treatment goals. Next slide. Some of the options, we'll start with lifestyle changes. Weight management is very important. Because obesity and increase in weight is a risk factor for both heart disease, but of course also for sleep apnea. Stop smoking, for example. So decreasing many of the risk factors that we talked about through lifestyle changes. Exercise has been shown to, in conjunction, for example, with other treatments for sleep apnea, to enhance those treatments. But the most common and medically accepted treatment is continuous positive airway pressure, what we call CPAP. And what this does, as you see in this slide, this young woman with a mask on her nose, this mask is hooked to this, to this tubing that goes to a machine that produces positive airway pressure. So it's like a reverse vacuum cleaner, pushing pressurized air at different levels through your nose into your upper airway. So it's like an air splint. It's keeping your airway open. And to do this test, you actually have to be titrated, which means that not everyone different people will require different amounts of pressure. And that needs to be done either in the lab or it can be done at home as well to determine your optimal pressure. More recently, in the last 5 years, we have these oral appliances. This is something a dentist will fit you for, and we'll talk a little bit about that later. And there's also the surgical option. Next slide. The lifestyle changes we talked about. This is weight, quit smoking. I already talked about this. Avoid drinking alcohol, particularly very close to bedtime, because it can make your sleep apnea worse because it relaxes those muscles that are already collapsing. Sleeping on your side can help, but usually by itself is not sufficient in stopping the sleep apnea. Next slide. Very important to get enough sleep. to make sure that you have a good sleep hygiene, especially if you have trouble falling asleep or staying asleep. A warm bath, listening to calming music is what we call good sleep hygiene. But again, that in itself is not sufficient in general to treat sleep apnea, but it can improve your sleep quality. Reduce stress in your life, it's easy to say, but of course it is difficult to predict and manage. But there are ways that you can do this through exercise, through meditation, for example. If you have a lot of nasal congestion, consider saline or nasal spray, saline rinse that you can buy over the counter. Those can be quite useful. And if there is depression or anxiety that's associated with your sleep, it is best to also refer to a professional who can help you with that. Next slide. We talked about CPAP a little bit earlier. You can see another picture of this. In the first picture, the mask was placed over the nose. In this picture, you can see that the mask is placed over the entire mouth and nose. This is what we call a full face mask. This is for individuals who are big mouth breathers, and they cannot, and we have to keep the mouth closed. We have to get the pressure also through the mouth. So not everybody will need this. Some people will need it. The majority of people will just wear it over their nose. The CPAP levels can be adjusted periodically, and I think it's a first-line treatment because it has been shown to decrease some of the risk factors that we talked about. It can decrease blood pressure, it can decrease inflammation, and also it can improve glucose control in people with, for example, with diabetes. Very important, one of the reasons why people can't tolerate CPAP is because their nose is congested and it's stuffy, because the air has to get through your nose. And so the nasal decongestions, as well as addressing that either with by going to an ear, nose, and throat doctor, and or just your primary care doctor or your primary care health provider, can be quite useful. Next slide. This is another picture. This is a nicer picture. This is what we call another type of mask. This is a nasal pillow, so they don't go over your nose, but there's little prongs that actually go inside your nose. This is one for women, and the nice part about this, you can see, is that it avoids, it prevents the tube, not the tubing, but the straps allow for your hair to be less, I guess, affected than some of the ones that kind of go over your head. It's a first-line treatment. It does reduce sleepiness in many individuals. It can improve sleep quality of life, improve cognitive functioning. As I said earlier, glucose control, blood pressure levels can go down. I think very importantly, reduces cardiac risk and reduces mortality rates. These are all been shown in various studies in both men and women. Next slide. This is the mouthpiece. This is the oral appliance that we spoke about a little bit earlier. There's several options. This is what your dentist would fit you for. This is really recommended for people who have mild to moderate sleep apnea, or who can't tolerate CPAP. Really, the first line, especially for more moderate, severe apnea, is the CPAP. Next slide. Surgery is not typically a first-line treatment. For some individuals, it may be, especially if they have very large tonsils or adenoids, such as in children. But usually for adults, that may not be the first-line treatment. CPAP or an oral appliance are actually covered by insurance and are the medical treatments of first line of choice. The problem with surgery is that it is not reversible, and there can be side effects, and depending, and the rate of success is probably at best about 50%. Next slide. It's really important to stick with your treatment, especially for sleep apnea. It is a chronic problem. You need to partner with a healthcare provider to map out this treatment plan, adopt a healthy lifestyle, as we spoke about, especially with regards to weight management, and report any reasons why the treatment isn't working, especially if you've been prescribed a CPAP machine and you're not tolerating it. There are many masks on the market that you can use. There are other machines that can be used, and also nasal stuffness. Just keep trying, talk to your healthcare provider to make this a treatment that can work for you. So I'm going to stop now. I'm going to give it back now to Emily.
Okay, thank you, Dr. Z. So now we're going to do our final poll question. I'm going to go ahead and read it to you and then open it for everyone to go ahead and vote. So the poll question is, do you talk with your healthcare provider about how sleep might affect your heart health? Okay, I'm going to go ahead and close the poll. Thank you so much, everybody. And Dr. Z, back to you.
Thank you. Some of the must-ask questions for you and certainly your healthcare provider: how do I know my fatigue might be something more? What might be causing sleep apnea? I think that these are some of the questions that we have. Are there other likely causes for my symptoms other than I'm just tired, I'm not getting enough sleep? Should I see a specialist? Yes. I think if you have any of these symptoms that we talked about, you should see your primary care doctor first or your primary care provider, and then, if needed, a sleep specialist. How do you prepare for a sleep study? One of the things is it is an overnight sleep study, that if it's in the lab, you should come with your comfortable clothing and be prepared to arrive around 8 or 9 p.m. or a little bit earlier, to have eaten your breakfast. If you take special medications, to take them before you get to the sleep center, and or let them know that you will be taking medication. Some sleep centers will or will not allow that. So be prepared for that. The insurance companies in general will cover a sleep study, but for many individuals, you will have to get a pre-authorization. Some companies now will require that you have a home sleep study, like the one that we talked about, what we call the portable sleep study, and others will allow you to have a sleep study in the laboratory. So you need to talk to your healthcare provider about that and get a pre-authorization in most cases. What's the best treatment available really depends on the severity of the sleep disorder breathing or the sleep apnea, the types, your anatomy, the types of treatments that you may be able to tolerate, including CPAP. As I said earlier, CPAP is a first-line therapy, but there are individuals where that may not be appropriate. If you have other health conditions, especially I think if you have diabetes or heart disease, it is really important, I think, to more aggressively treat the sleep apnea because it is a risk factor for worsening of those conditions. Being tired is such a common problem in our society. Being sleepy is also a common problem. But I think if you snore, if you have stop breathing episodes during sleep, and you are sleepy, tired, and any of these symptoms, it is very simple to actually get screened for potentially having sleep apnea and getting treated appropriately. Next slide. So several things to keep in mind. Sleep apnea has been linked to multiple cardiovascular problems. Many women are undiagnosed because they think it's a male disorder, and also their symptoms are a little bit different. They may present, for example, with insomnia. And it's not always about your weight. You can have sleep apnea even if you are of normal weight. Very important to bring this up with your healthcare provider and find out why you're so tired. It may not just be because you're not getting enough sleep. It may be that your sleep quality is poor due to sleep apnea. Next slide. So in summary, I think that research shows that there is a role of sleep apnea in cardiovascular disorders, and the take-home message is rather than attributing sleep problems to only hormonal changes, especially in menopause or in pregnancy, think about other medical disorders, particularly think about sleep disorders such as insomnia. We talk a lot about sleep apnea, but also restless legs. Also more common in women. Medications that could be affecting your sleep, psychiatric, psychological conditions, and very importantly, what we can all improve is our lifestyle, including diet, exercise, and watching both our caffeine, but very importantly for patients with sleep apnea, their alcohol intake. Next slide. Some of the resources that can be very helpful are listed here, but I will point you to the National Heart, Lung, and Blood Institute, the Women's Heart, the National Coalition for Women with Heart Disease has wonderful information provided to you here, and the American Academy of Sleep Medicine. These are all just really, really helpful websites for you to go to. And now I'm going to take this back to Emily.
Okay, great. Thank you so much, Dr. Z. Very informative. So now we are going to move on to the Q&A portion of the webinar. In order to participate, you need to type in your question in the question box on your control panel. Once your question is complete, click Submit. Your question will then appear on my control panel, and I will read each question out loud so that Dr. Z can answer each question. I will answer and I will read each question in the order in which I receive them. Once again, thank you to our webinar sponsor, the ResMed Foundation. And once you're all ready, you can go ahead and submit your questions, and I'll start reading them to Dr. Z so she can answer them. Okay. Okay, so our first question is from Jennifer. How do you combat dry mouth when you use CPAP or oxygen? My dentist says I now have dental root caries because of my dry mouth.
The best way to combat that is with a humidifier, and most of the CPAP machines come with a humidifier. You can put it on a higher level humidity and also have the heated option. So kind of watch for how much humidity is in the mask. One of the problems, if you're actually having a dry mouth while on CPAP, it means to me that you're opening your mouth with CPAP, and that makes the CPAP ineffective. So a full face mask may actually be a solution to that, and or what we call you can wear a little splint that keeps your jaw closed, but usually it will be a full face mask.
Okay, great, thank you. Our next question is, I read recently that Northwestern was doing a study which used the pill to treat sleep apnea. Could you elaborate a little bit on that, Dr. Z?
Yes, indeed. We are using, it is an NIH-funded study that is in what we call a phase 2, so it's in the relatively early stages. It is, we're conducting it both at Northwestern and also at the University of Illinois. It is a medication that is what we call a cannabis mimetic. And if you know, it comes from the word cannabis, which is the active ingredient, THC, which is the active ingredient in some forms of marijuana. This is not marijuana. It does not necessarily give you that high. There's different kinds of cannabis. But it is a pill. It is a medication called drobananol, which is available on the market, approved by the FDA for a different kind of treatment, not for the treatment of sleep apnea. So that's what we're looking at, and it's a 6-week treatment trial, and we are recruiting for patients. And you may wonder, well, how does it work? Well, I think we don't know for sure, but there's some preliminary data to show that it has potential and it may work by tightening some of the muscles in the upper airway.
Okay, great. Thank you so much. Our next question from Stephanie is, what is the difference between a CPAP and a BiPAP?
Yes, a CPAP is, the C stands for continuous positive airway pressure. So it's giving you a steady flow of pressure. Let's say it's 7 centimeters. It's always giving you 7 centimeters. The BiPAP is a bi-level. So it's got a different pressure for going for the, when you inhale, the inspiratory pressure and the expiratory. It's usually for individuals who need a very high level of CPAP, let's say above, let's say 15 or higher, so that you can give a higher pressure when the air has been pushing in, and a lower pressure when you're trying to breathe out, so you're not breathing out against such a high pressure. So most of the time it's used for comfort reasons. There are also other situations where you may use a bi-level, and this is for individuals whose oxygen may be low or who have difficulty breathing. And then you use the bi-level actually to help ventilate or help the person breathe. A CPAP really is not a breathing machine per se. It's actually more of an air splint.
Okay, another question on CPAPs. How often does a CPAP need to be reevaluated?
The CPAP should be, if you're on a good, if you're pretty stable on it, you've had it for a while, you should see your healthcare provider at least once a year for a new prescription. If you're doing well, there's probably no real reason why you need to have another sleep study. If you're not doing well, for example, if you've gained weight and or your tiredness, sleepiness, or other symptoms have returned, your blood pressure is now higher, for example, that may require another look at whether your level is adequate. So once a year, visit your healthcare provider, and every 6 months at least to get some new tubing and a new mask.
Okay, great. So this next question, for women who already have heart disease, is there evidence that CPAP or other interventions reduce subsequent cardiac events?
There is, it's a great question. The longitudinal data, the actual double-blind trial studies on this has not been actually performed well that I can say, well, this is definite. But it does, but treating sleep apnea does decrease the risk factors that can exacerbate or can lead to heart disease, such as high blood pressure, metabolic parameters, and also inflammation.
Okay, great. So Vicki wants to know how she can try out different types of devices to find out which one is right for her. Does she have to buy them each time?
For the CPAP, you would have to you don't have to buy them, but you would try it by going into a sleep center. It has to be titrated, so it isn't something that you just buy and you say, okay, let me just see what level I will need, because you won't be able to tell that. There are auto titrating devices as well, but that's something that you probably wouldn't be able to buy. It is by prescription only, so that's how you would try it in a sleep lab to see whether it works for you. The oral appliance, you would have to have this made for you by a dentist. Again, it isn't something you can just take off the shelf and try. So yes, the oral appliance, you would have to buy it. The CPAP machines, they can also be rented, and oftentimes some of the insurance companies will allow you to do that. And actually Medicare will in general just rent it until for the first year or so, until the unit is paid off and or you are able now to own the unit. Okay, so there's not really off-the-shelf trial periods for most of this.
Okay. All right. So Donna wants to know, she has CAD and severe sleep apnea. Her tests showed an average 80% oxygen. She has a CPAP nose pillow mask and she wants to sleep from 10 to 11 hours a night, but she still wakes up tired, and her leak level is 1 to 6%, and she's curious if she's not getting enough air through the mask.
Well, that would be, I can't specifically answer that question. In general, sleeping 10 to 11 hours is on the long side. We, in general, recommend, unless you're a teenager, to be sleeping probably just about 9 hours, somewhere between 7 to 9 hours. So it may indicate, I'm not sure. The leak level seems to be okay, but they can truly vary from mask to mask. So I don't know what mask you are using. But if you're still tired, if you still don't feel like your sleep is of good quality and refreshing, you do need to go back to your healthcare provider and try to see and determine whether the pressure level is adequate for you. You also have a little card in the back of your machines, we'll call compliance card. You want to take that and get that downloaded and see whether that is that you are using it, because it'll tell you a little bit about what your apnea-hypopnea index is on this machine and at the level that you're using. So it's really good to follow up.
Okay, thank you. How often are you allowed to have a sleep apnea test?
Well, that's a good question. Depends on your insurance carrier. Mm-hmm. You are actually allowed to have a sleep apnea test when you need one. It doesn't mean you have to have it every year. I have patients who don't have any for years. But if, for example, in the example right before, if the individual is not doing well, or their symptoms remain, or the doctor or healthcare provider, let's say your nurse practitioner, thinks that the pressure may not be adequate, or you need a different kind of machine or titration, that can be done. I've had this done even within the same year. But CMS or Medicare does have some restrictions on that. But your healthcare provider can certainly help adjust that. And sometimes you just don't need another sleep study. There may be other things that you can do to address the issues that you have. So it has to be, the need is based, the frequency of a sleep study is based on the need for a sleep study.
Okay, great. Okay, so someone in the audience has been checked for sleep apnea and does not have it. Their lack of sleep is a learned behavior. That's what the professionals say. She has fatigue, dry mouth, and headaches due to only 4 to 6 hours of sleep a night. Do you have any suggestions for her?
Well, I don't have specific suggestions for you, but I think that if you wake up with a dry mouth, you're breathing through your mouth, it may be reasonable for you to go see your ear, nose, and throat doctor and see whether, your upper airway, whether you've nasal congestion. That could also be decreasing the quality of your sleep. I would also recommend to see a sleep specialist regarding your lack of sleep and perhaps some of the insomnia symptoms that you have that may or may not be related to sleep apnea. There's also this condition called just increased upper airway resistance. It does mean that you have some resistance in your breathing during sleep, but not sufficient to cause these desaturations of your oxygen. But it can actually disturb sleep a good amount, and that can and should also be addressed.
Okay. Denise has experienced vertigo since began using a nasal pillow. Is there a correlation between the two?
Yeah, I'm sorry that I don't know whether there is a definite correlation between vertigo and the nasal pillows, but the CPAP and also the whether it's nasal pillows, these masks, because of the pressure that's producing, it can change in some individuals the balance of the fluid level in your ear inner ear canal. So that could be a potential mechanism. You may want to just switch to a, instead of a pillow, just a nasal mask and see if that makes any difference, because the pressure would be less direct.
Okay, great. So we only have time for 3 more questions, so these will be the last 3. Okay, so this woman has been having sleep problems since beginning menopause, and she was born with a heart murmur and will need her valve replaced at age 52. Due to the valve problem, am I at risk for sleep apnea?
The valve problem has not, to my knowledge, been associated with a higher risk for sleep apnea. But if there are symptoms suggestive of sleep apnea, it would be a good idea to have the sleep apnea managed and treated, because you don't want to put more work on your heart.
Okay, great. So if you have had an evaluation and were not diagnosed with sleep apnea, but you're still experiencing those symptoms, what should be some next steps?
If your sleep study did not show sleep apnea, but you have some of the symptoms, I would definitely go see a sleep specialist and describe those symptoms. And it may be, as I had mentioned earlier, a condition called increased upper airway resistance, and what you may be having is what we call these respiratory-related arousals. Maybe just taking care, maybe you have nasal congestion, for example, or some narrowing of your upper airway. All of those can cause some of the symptoms associated with sleep apnea, but not be severe enough to actually, to actually show up on a sleep study as sleep apnea. So go see your doctor and maybe have him refer you to a sleep specialist.
Okay, great. And here's our last question. If you are diagnosed with sleep apnea, does that mean you will always have sleep apnea?
It is a chronic condition, and so you're more likely to continue to have sleep apnea. But of course, that depends on the cause of the sleep apnea. If it is, if you are overweight or obese, and you lose a significant amount of weight, that can actually, I have seen individuals where their sleep apnea no longer is either in the moderate range, it can be in the very mild range, or very low, and they may not require further treatment. If it's due to some type of obvious anatomical obstruction, and that is corrected, that can also help with the sleep apnea. So it really does depend on the cause of the sleep apnea, but in general, it tends to be a condition that is chronic.
Okay, thank you so much. I just want to thank you all for taking part in our webinar today. I would also like to thank our webinar sponsor, the ResMed Foundation. This is a really interesting topic. Dr. Z, do you have any parting words for our audience today?
No, I would like to say thank you, and for sponsoring this, and thank you to the participants, and may you all sleep well.
Great. Okay, so this concludes our webinar. You will receive a follow-up email from GoToWebinar tomorrow. This will include the link for the webinar recording, and that will be located at Women Heart TV on YouTube, so you can watch it again if you need to. You will also receive in that same email a link to the post-webinar survey. We would greatly appreciate it if you took the time to complete this survey. It takes about 3 minutes, and it will greatly help Women Heart. And also, if you have any additional questions regarding this webinar, please feel free to email me. It will also be, my email address will be in the follow-up email. Again, thank you all so much for joining us. Have a great evening.